In this week's Your Health segment, Dr. Robert Reed, Assistant Professor of Medicine at the University of Maryland School of Medicine and transplant pulmonologist at the University of Maryland Medical Center. Doctor, thank you for being with us. We want to talk about COPD, which is chronic obstructive pulmonary disorder. What does all that mean?
So chronic obstructive pulmonary disease is the third leading cause of death in the United States. It's a devastating illness. The first two leading causes of death are cancer and heart disease, and those as well are linked to COPD, and it causes a significant amount of morbidity in the lives of those who are affected by it. There are over 15 million Americans who have it, and up to 15 million who are not diagnosed with it but have it. And to put that in context, there are a few over 300 million Americans, so somewhere between 5 and 10% of them are walking around with some degree of COPD.
What's the relationship between COPD and emphysema or chronic bronchitis? That's
a great question. COPD is the larger term, and chronic bronchitis and emphysema are subtypes of COPD. Chronic bronchitis is defined as having a cough that's productive for 3 months, 3 out of 2 consecutive years. Emphysema is really a diagnosis that is a pathological diagnosis. It's a dissolution and dissolving, if you will, of some of the tissue within the lung.
Who is affected by these?
Well, it's mostly smokers. 80% of people with COPD have a significant smoking history, and if you say, well, oh my gosh, I smoked last week, could I have COPD? It's really a lot of smoking required. We talk in terms of pack years. If you smoke a pack of cigarettes for a day for an entire year, that's a pack year, and most research studies require at least 10 pack years of smoking to consider the diagnosis of COPD likely. And you can either get that through smoking a pack a day for 10 years, or if you want to fast track it, you can do 2 packs a day for 5 years.
Not recommended.
Bad idea.
From a demographic standpoint, folks in your waiting room tend to be what age?
Well, most of the folks that I see are 40 years of age or older. It mostly hits people in their late 50s, 60s, and as you can imagine, it gets more and more prevalent as we get older. It is a disease that hits us more and more over time. As you ask about the demographic, it used to be considered that men develop COPD and women get asthma. That has really changed, and COPD is primarily a problem that we see amongst women now.
What changed it? What accounted for that?
Maybe Virginia Slims. I'm not entirely sure. I think that it's just the changing patterns of the medical profession, seeing that yes, this disease that we're seeing in women is indeed COPD. Women did begin smoking more and more during the suffrage movement, and there seemed to be genetic predispositions, and women just seemed to develop COPD with a lesser burden of smoke exposure.
Now, what about that 20%, I guess, that didn't have a smoking history? How did they get it?
Right. That is an interesting question. It is usually that they inhaled something that wasn't good for them, and it could be silica exposure, dust in the workplace. It could be that it was in this overlap with asthma that was inadequately controlled and progressed on to become COPD.
What's your thinking on marijuana smoke? Because it's a big political debate now. You know, the state has taken some steps towards decriminalization of it, even medical use of it. Does any smoke have the same impact?
If you inhale things that don't belong in your lung, it's going to do damage to the lung. I think that it's interesting. I can't say that marijuana smoking is good for you. It's not a good thing for the lungs in any way. In fact, you breathe in more deeply when you smoke it, and that can do damage. It's interesting to me that the tobacco companies are some of the greatest opponents to tobacco smoke or to marijuana legalization, and there may be some reasons to think that marijuana smoking may be in their disinterest. Medically, it's all a bad idea.
We'll talk about the treatment side. Let's get a phone call first. This is Joseph in King George, Virginia. Joseph, thanks for the call. Go ahead.
Yes, I would like to know, like when I was in the Navy years ago, I was involved with burning a lot of paper, top secret paper and stuff like that in a generator, and the smoke was coming out, a lot of black smoke. Could that cause COPD also?
Joseph, thank you, sir.
Well, Joseph, thanks for the question. That's a great question. I'm very honored to have the opportunity to take care of some veterans, and their service is greatly appreciated. Absolutely, inhaling things that don't belong in your lung is bad for your lung. It's true. There are now it's hard to say whether a little bit of smoke exposure would lead to COPD per se. It takes a pretty good period of time and a good amount of smoke for that kind of damage to occur. Now, there are other illnesses that can occur with lesser exposure, such as reactive airway disease.
Let's talk about the treatment side of this. What are the mainstays and what's on the horizon?
Well, there are a tremendous number of inhalers available for COPD. And when you boil it all down, really there are only three major classes of those inhalers. And two of those classes of inhalers work very similarly by dilating the airways. The third class of inhaler is an inhaled corticosteroid that's intended to reduce the inflammation of the airways themselves. These are the same primary agents that we have for asthma, but some of the treatments are approached a little differently. In asthma, it would be a good idea to begin with an inhaled corticosteroid agent alone. In COPD, that would not be the best first agent. In an asthmatic, using a long-acting beta agonist, which is a type of an inhaler, would be a bad idea alone, whereas in COPD it would be a good idea alone. So there are some subtle differences in the way that we juggle these inhalers. And then there are a variety of pills and other medications that we can use. And when to use them is a bit of a sophisticated question. I don't think I can answer it in 15 minutes.
Let's take another call. Baltimore County, this is Andy. Andy, thank you for calling. Go ahead.
Yes. Hi. I was just wondering, is this similar to silent ischemia? And what would the treatment be for silent ischemia?
Andy, thank you, sir.
Well, thanks for bringing that up. That's a great question. And in fact, there is a strong association between COPD and other illnesses. One of them is silent ischemia, coronary disease. And if you look at people who have known coronary disease, their underdiagnosed lung disease is in association with those folks. The same is true of people with COPD. They have more coronary disease than is truly appreciated. And it's frequently because the symptoms are quite similar. They both can present with shortness of breath. Heart problems can actually be accompanied by cough as well, which is one of the sentinel symptoms of COPD. And so there can be a lot of confusion between those two, and it really requires a conversation with a physician to try to tease out whether you have one condition or both.
You mentioned there's a lot of people out there who have it and it hasn't been diagnosed. What are they feeling? What are the symptoms that they need to get checked out?
Well, the symptoms of COPD occur in a spectrum. There are some people who have primarily cough, and that cough is similar to asthma. Frequently, it's oftentimes more sputum, more phlegm that they're bringing up. The other sentinel symptom of it is shortness of breath, and that can initially develop with exercise only and then progress to the point where they're short of breath even at rest. And it can be extraordinarily disabling, such that in the extreme cases, people are really confined to their own homes and unable to go outside of their own homes and live the kind of lives that they want to.
Primary care is a good starting point here?
Primary care is a great starting point here. You bet.
Very good. Dr. Robert Reed of the University of Maryland Medical Center, University of Maryland School of Medicine. Doctor, thank you for being with us.
Thanks for having me.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.